Somebody has their. And can I point to people as they introduce yourself? Like, can I tell them, or I just call out their name? I think you call them. Okay. Dr. Carol, are you there? Can you hear me?
Yes, I can.
Hi. Do you have someone there with you?
Yes, Dr. Wallace, Dr. Baby Wallace is with me. We're learning this computer as well, so we'll just maybe this way.
This is definitely kind of a dry run here. We'll have content, but it's going to be half of it's going to be figuring out the technology. And I think we're going to have, this. I don't know. Let me just ask, as we're setting this up, the information that I sent out. Now I'm looking back at it because we were just trying to frantically get ETSU Family Medicine up. We probably need. How did you find it? Do you think it's clear enough, or do we need more of a step-by-step process to show people how to log into a session?
I think a little more detail. I'm having some problem with the Zoom. I kept getting error message from my computer, but I don't know if it was my computer or that's what we're trying to sort out. But yeah, I think step-by-step usually helps me.
Okay. Well, are we set with Family Medicine? You have the cameras on us, projected on the screen.
I can't see Ben.
Okay, and Min, can you hear us?
Yeah, I can hear you.
Okay, do you want to turn on your video so we can see you? He's good about muting.
Okay.
There you are.
Hi.
Everybody's eating lunch, so don't worry about chewing during the presentation. Just don't speak with your mouth full. That's my mother always taught me that. Well, why don't we go ahead and get started? As I said, I think that we have promoted this to a number of folks, but I think some of the technology issues we'll just have to maybe put some really basic step-by-step instructions. But we have a good group to start. I want to welcome you all to our first Project Echo session. I'm David Wood, Chair of Pediatrics here at ETSU. And sitting next to me is Kathryn Xixis, our pediatric neurologist, who is our expert. And just to give you an overview of the session, is what we're planning to do is present 2 cases, then have discussions, and you can always feel free to interrupt, ask a question. We can see all of you, so all you really have to do is unmute your mute and then say, hey, can I ask a question? So it's not hard to do that. I'm hoping that you folks there can see everybody else. Is that true? Nodding's good. Zoom is working. And so, but do please mute if you're not going to be saying anything so there's no background noise. And then we're going to have, after the 2 cases and we have a good discussion, we're going to move to Dr. Xixis' presentation, which we have on PowerPoint, which Brian is going to help us figure out how to put up there. And that'll go out to a full screen. You'll be able to see the PowerPoint and hear Dr. Xixis talking. But again, you can always interject a question. So those are the ground rules. Why don't we go ahead and then introduce ourselves. Dr. Quinn, do you want to?
I'm Maggie Quinn. I'm sorry, I keep forgetting. I just got married. I'm a pediatric nurse practitioner in Lenoir City with Cherokee Health Systems.
Where are you located?
In Lenoir City.
Okay. And where's that? I'm not that geographically savvy yet.
It's south, right? Is that right? Of Knoxville? I don't even know.
Oh, okay. Are you with the Cherokee Health System?
Yes.
Okay, great.
Yeah.
Great. And Min, do you want to introduce yourself?
Yeah, hi. I'm a third-year pediatric resident. My name is Min Jung. I'm going to present a case for Dr. Xixis to answer today.
Great. ETSU Family Medicine. Are you there, Diane? I saw her run by.
I'm here. Yes, I'm here. I put it on. Put the hang on, mute. So yes, we're here. I will move the camera so that
This is
it doesn't
Diana
show up
Hyman,
here.
Program Director for Family Medicine here at Johnson City. She's very tiny.
Yes, there we go.
Not
Now
in real
we'll see.
life though, but on the camera she is.
Hey, there's Terry too.
Oh, okay, great. We got some folks there.
Yes, there we go. Woo.
Hey. Okay, I'm getting dizzy now. Okay,
Sorry, yeah.
Dr. Wallace, you want to introduce yourself and Dr. Carol? Ms. Carol?
Oh, yeah. Phoebe Wallace. I'm the Director of Primary Care Services at Cherokee Health System. And with me is Hannah Carroll. She's one of our nurse practitioners, family nurse practitioners. And we're presently located in Knoxville.
Great. Dr. Johnson, would you like to introduce yourself? Dr. Barney, why is he there?
I don't know.
Okay. I'm Dr. Helen Johnston. I'm in Highlands Pediatrics. And so I'm doing it off my laptop with the audio, with the video, and Sarah's behind me. And Pam's over here.
Oh, we got 3. Great.
And that we're using, so you'll see another access with Highlands Peds. Because I can't hear off of this microphone.
I think that might be some of the reason you're getting feedback because you have 2 systems open at one time.
We have 2 systems. So I'm going to mute.
Okay, that's helpful. But we can understand you. It's not so bad. So if you guys want to ask a question, please feel free to jump in. Barty, DR, that's Dr. Barty. Are you here on the line? You can unmute. No, looks like maybe that's I don't know where. I show another person here. Okay. Well, those are the folks on the line. Thank you so much for coming and attending. And with that, we'll start with the first case. Dr. Jung, would you like to present the case?
Okay. So the case that I was going to present is a patient that we saw in our clinic. He is a 3-year-old male who came to the clinic after febrile seizures. He is reported to have 3 simple febrile seizures in the last 3 months. So he had 1 febrile seizure, and after a month, had another one, and another one after another month. All of them were simple. He returned back to baseline. He did fine, and he came for a follow-up after an ER visit for the febrile seizure. He looked fine at the clinic. Exam was all normal. He didn't have any issues. Also, there was no pertinent past medical history, no significant family history for seizures, no surgical history, didn't have any allergies, or is not on any medications either. The only thing of note was that he had a mild speech delay, actually a little bit significant for his age. He was speaking maybe about 100 to 150 words, and he was only able to put together 2 words at a time. He was still not speaking in sentences. There was a concern in the social history as well, that there was concern for neglect, and there was a DCS case open for that, and a lot of people are involved. I'm looking into that situation. So there was a question of whether this speech delay was just a product of the neglect, or if there was something else underlying that was causing that. So the question that we had regarding this patient was, obviously with this simple febrile seizures, we don't do a routine workup, especially if the patient had no developmental problems. But with this kind of presentation, if there was 3 simple febrile seizures in a span of just 2 to 3 months, also combined with a mild speech delay that was a little muddy because of the social situation, what would be the best approach for workup and management would be the question for that, for the case.
Are there any other questions from the folks around about the case, or Dr. Xixis, do you have any questions for Min about the case?
Let's let anybody else go.
Okay.
Nobody.
Nobody? Okay.
So it sounds like you're pretty convinced that these are simple febrile seizures, but your concern is that there's also an underlying additional problem. Is that correct?
Yes, ma'am. There was they were all brief events, 1 to 2 minutes, just generalized tonic-clonic seizures, all returned to baseline. So pretty sure that they are, and that's how it was documented in the ER too.
Okay. All right. So when we think about febrile seizures, I think you've identified one of the most important things, which is to decide if it's simple or complex, because that really helps us dictate our workup. And certainly the fact that, there are other ongoing issues in the background are important to consider. But with how often febrile seizures happen in the general pediatric population, about 5% of kids will have one. I don't know that I would treat this kid any differently per se, as long as he does meet the criteria for simple febrile seizure. Certainly that's something we need to remember in terms of his history going forward, but I don't know that I would do anything different. What did you guys do any sort of workup at all? What was your approach?
So we ended up just sending for a routine EEG just to make sure. The only concern was they were frequent, and also there was a piece of a developmental delay, which of course was kind of confused, was kind of muddied because of the social aspect. So we weren't sure if that was playing into it. If that was a pure product of that, or if there was something underlying. So that's why we went ahead and got a routine EEG. The results we don't know yet.
Was the rest of his physical exam also normal?
Yeah, the entire exam was normal.
Any neurocutaneous stigmata, anything like that you would be worried about? Maybe pointing to something different? No,
not that anything was noted. Yeah.
Okay. So, we'll talk about this a little further in the didactic portion, but anytime you have a true simple febrile seizure, really for that particular indication by itself, even an EEG is not necessarily necessary. You definitely don't need to get any imaging or that sort of workup. When you think about the speech delay, I don't think that you were wrong to get an EEG from the setting of, is there something going on from a delay perspective? But purely from the simple febrile seizure perspective, it wouldn't necessarily be, you wouldn't definitely have to get one. I think the biggest concern that you probably brought up is that there were so many episodes and that they were so close together. It sounds like 3 of them in 3 months. And so that is a kid who, we may get into, is that a patient who would benefit from maybe a benzodiazepine bridge when they're ill, if they're really having febrile seizures that often? And so in terms of an intervention, I think thinking about a bridge for a patient in that scenario would be probably the most important change or kind of intervention that I would think about making.
And so if you were going to then order that medication to cover his febrile illnesses, when would you start it, and how do you determine how to administer that medicine? Yeah,
so typically with benzodiazepine bridges, there's been a lot of research about them. They first started kind of coming out with some information in kind of the 90s, and multiple benzodiazepines have been studied. Clonazepam is probably the most frequently used at this point. And typically what we'll recommend for kids with febrile seizures that are recurrent, that are just so often, is that you give it twice a day for 3 days during the febrile illness. It's definitely not perfect. It's a little tricky because, as you guys know, simple febrile seizures or any febrile seizures often really may present as the first sign of the illness. And if that is the case, it can be very difficult to prevent them, unfortunately. What we're really going for in a patient who has very frequent repeat febrile seizures is to prevent recurrent ones within the same illness, or to prevent it if they actually do show signs of illness prior to it. And so it's really just a temporizing measure. We don't feel like these patients need to take a medicine every day, but certainly we don't want them to have so many seizures if we can avoid it.
One other question that comes to mind with that is, so in a setting of repeated febrile seizures, simple febrile seizures that wouldn't typically require a workup, if that was combined with any form of developmental delay, at what point with repeated simple febrile seizures combined with the developmental delay would you consider any kind of workup, like a routine EEG?
Yeah, so I think that you have to consider them as 2 separate issues. So purely from a simple febrile seizure standpoint, I still really wouldn't recommend workup. And then I think you can look at the developmental delay really as a separate issue. I think if there's developmental issues in multiple areas, certainly we're more inclined to do a further workup. If there are abnormalities on the exam that suggest from a developmental standpoint that a workup should be done, then I certainly think it's indicated. But I would really consider those two separate things combined with simple febrile seizures.
Okay, thank you.
Yeah, of course.
Any other questions? Helen, when you're raising your finger there? We just lost her from the screen there.
Yeah.
We want to welcome Brianna Dennis. Hi, Brianna?
Hi.
Oh, we can hear you now.
No,
We can barely hear you.
I'm in a very small room.
Oh, now you're good. Now you're good. We can hear you. Great. Tell us where you're dialing in from.
I'm dialing in from Cherokee Health Systems in Knoxville.
You have good representation from Cherokee Health. Thank you so much. This is great. Another question about febrile, like recurrent febrile seizures. What characteristics of the seizure would cause you to, are there characteristics of the seizure beyond just simple that would make you also want to prescribe, say, prophylactic medication? And the second part of that question is, when would you use something like Diastat as opposed to a continuous three days of benzos versus a rescue?
Let's take one at a time. I'll probably forget the other one while I'm talking. But let's talk about the Diastat first, because this is a question that comes up a lot, and I'm sure it comes up a lot for you guys as well in primary care. So there's no right or wrong answer to when to start to prescribe Diastat to a kid with a febrile seizure. You can do it after a single febrile seizure. I will tell you that often I wait unless that particular febrile seizure was complex and very long, or something about it was very concerning. The reason is a lot of children will never have another one. And, rectal diazepam is a very expensive medication. I've heard it's like $300 or $400, and most kids are never going to use that. So that, to our healthcare system, is probably not the best use of money. If there's anything scary about it in terms of length, which would make it complex, or anything that, if they present with a febrile seizure that's 2 hours long, that's a different story. But yeah, that would be status. But after they've had 2 or 3, I start to prescribe a rescue medication just for them to have it available. And typically in this age group, that is the rectal diazepam. That's going to be for febrile seizures over 5 minutes, whether or not they've had one that long in the past. If they're having that many, I do tend to go ahead and give them a prescription for it. But certainly the role of the benzodiazepine that we're giving as a bridge during febrile illnesses would be to prevent. The role of the rectal diazepam would be obviously to stop the ongoing seizure. I already forgot your other question. You forgot it too.
I forgot it too. Oh, are there characteristics? You kind of answered that. Okay. So what characteristics of the febrile seizure would also make you more likely to medicate early rather than late?
Yeah,
so it's the length of the seizure.
So seizures that have a more complex presentation, typically in the setting of either they had multiple, they showed up with 10 that day, and that's why it was complex, or they showed up with, a very long seizure. Those are probably reasons that I would have a lower threshold to go ahead and either prescribe a benzodiazepine bridge, or to definitely go ahead and send them home with a rescue medicine, as we talked about.
I have a question.
Yes.
Can you hear me?
Yes.
Yes.
Okay. So you do not recommend EEG if they've had multiple febrile seizures? Simple.
Correct. So if they have had a simple febrile seizure, the most recent guidelines, I guess is the word, from the American Academy of Neurology is that we know that children have recurrent. We know about 1/3 of kids have recurrent and multiple febrile seizures. And as long as they still fit the simple category, there's no real indication to do an EEG.
You want to review the criteria for simple again?
Yeah, we will, and we're going to talk about it further in a few minutes. But so by simple, that's a good point. So when we're talking about simple versus complex, it can be a little bit difficult, often because the parents have panicked. It's hard to get the information. They were on their right side, so we're both sides shaking. I don't know. I mean, I have the same problems you guys do with getting all of the full history. But criteria are that there is no focal component to be a simple febrile seizure. It lasted less than 15 minutes, which is different than the timing we think about for other seizures, and that there was only 1 in 24 hours. So if you're meeting that criteria, then you're meeting the criteria for a simple febrile seizure. If there's anything about that that does not meet the criteria, even one of those things, that automatically will put you into the complex febrile seizure category, and we do recommend an EEG for anybody in the complex seizure category, certainly.
And then the other thing just to mention was you realize this is a family that's already undergoing DSS. And so when you were talking about your bridge medicines and rectal Valium, I was like, man, this is not a family I would be sending that home with.
Mm-hmm. Yeah. So, I mean, I certainly think you have to think about, you know, the risk and benefit. We obviously in neurology dispense a lot of benzodiazepines by nature of the subspecialty. And so typically I will keep a very tight rein. I will give them only enough, for example, 1 round to use for 1 round of a febrile illness. And if they're needing repeated refills, they need to be either coming back to the office or we need to be talking about what exactly is going on. So there's still an indication to use the medicine. There's definitely an indication to give rectal diazepam. But if they are needing refills, then we need to talk about what's going on with the kid.
I mean, it struck me when you said it's under 15 minutes, which is the definition of simple. That's a long time for a family to watch a child have a seizure. There's probably a lot of pressure that comes from families to prescribe something. How do you answer that if you really don't think it's indicated, but they're asking for something? Yeah.
So the only thing that I will give into is the rectal diazepam. So if the family feels very strongly that they want to have something to stop it, again, it's not contraindicated or wrong at all. In some cases, you could say it's right to go ahead and prescribe it after the first time. Since there is no right or wrong answer, I'm happy to do that if the family feels strongly about it. But especially for short cases, again, with the idea of the medical care dollars that we're throwing out with rectal diastat, I let them know this is available. You know, it's a risk-benefit discussion. This is when we would use it and what we would use it for. And if they feel strongly about having it, that's fine. I do give them a prescription.
Do you think that's within the purview of the general pediatrician or general primary care provider to prescribe rectal diazepam in this kind of setting?
Yeah, I absolutely do. ED physician or primary care physician, I think, is very appropriate in a kid who's had either recurrent ones, a long one, or, you know, if you're in the situation you would like to give it for a first-time one. I think that is very much something that can be done and is done by many of the pediatricians and family doctors. Once we see those patients, many of them already have diastat or rectal diazepam.
And if they do meet the criteria for complex, however they meet it, would you also recommend head imaging as part of the workup or just an EEG?
Yeah, so that's a great question. So complex febrile seizures are a little trickier. We definitely start with an EEG, as we just talked about. And the idea is that a lot of reasons that you have complex febrile seizures are just random. Maybe we had a poor history, maybe they had a bad day, so they had 2 of them. You know, but we also want to be careful. Are we missing the kid who really has epilepsy? And that's why they came in with a 90-minute seizure. Are we missing the kid who has a brain tumor? And that's why they came in with a focal seizure. So, you know, it's a risk and benefit. Everybody can't get a full workup for every shaking event. But if it fits the criteria for complex febrile seizure, we always start with EEG. And if that routine EEG is abnormal, at that point, it is recommended to go ahead and get imaging, MRI being preferred. And those are the guidelines of the Neurology Society.
So if the EEG is normal, they don't need the head imaging.
Correct. Okay. Correct. Yeah. Often they will have gotten a CT or something in the emergency department, but for primary...
You have to get a CT.
I mean...
part of the discharge process, isn't it?
But for entry process. But for a lot of primary care providers, they may you guys may actually see someone who hasn't had that. They didn't go to the ED, or you hear the story after the fact and you say, oh, I think that's what it was. And so that would be the process to get the routine EEG first. And then if that's abnormal, imaging would be recommended as follow-up for that.
If they got a CT, it's kind of irrelevant, right? It doesn't contribute a lot, potentially.
Yes, correct. So when you think about imaging, which is kind of a different topic, we won't go too far down that path, but when you think about imaging, the CT is going to show you if there's gross abnormalities. It's going to show you if there's blood, if there's a gigantic mass, anything like that. But when we're looking for a kid who may be at risk for recurrent seizures because they presented with a complex febrile seizure, the MRI is going to be a lot better. And on that MRI, we're not necessarily looking for tumor or hydrocephalus or anything like that, although we may find that. We are also looking for more minor abnormalities like dysplasias, so abnormal areas of the brain that are going to cause that kid to be at high risk for recurrent seizures in the future. And if we find that in a kid, we're going to follow them more closely and potentially start them on medication sooner because of that.
Great. Any other questions? I want to move quickly to the second case, which Dr. Toole was going to present this. She's in Florida and has bad reception due to, I guess, the hurricane. So passing through, it's already gone, right?
Yeah, it's gone.
But anyway, maybe she's out in a water park. I don't know. Anyway, I'm going to present her case. This is a case that a patient that she saw in clinic. And so forgive me if I can't answer all your questions about the case, but this is a 5-year-old who has actually a history of prior febrile seizures for which they had prescribed rectal diastat. But the mother describes a new shaking episode that happens at nighttime where a 5-year-old child was shaking all over. It started about 3 months ago, and she describes the episode as the eyes were closed, the child was shaking and doesn't respond when the mom tries to wake her up. It lasts 1 to 2 minutes. It's happening 3 to 4 times a week, sometimes 2 to 3 times a night. And the mother's sense is that the frequency is increasing over the past 3 months. She's had no evaluation for this, no head imaging in the past, no EEG in the past, no laboratory workup. Her general developmental trajectory is that she does have some mild speech delay, and she's getting speech therapy in school, but no other delay. So the presenters, or the Don's question to Dr. Xixis was, are these seizures that I need to medicate, or should I just refer to neuro for further evaluation?
Yeah, so I think the first question is, are they seizures? And I know you guys get this question at least probably more than I do, is, my kid jerks when they sleep. And so our question is, is the jerking myoclonic jerking? Is it normal jerking? Or is it true epileptiform jerking? It sounds like with the history of simple febrile seizures, the kid has never had an EEG or any kind of real workup. And in this case, it sounds like we're moving into really a history of febrile seizures, but an afebrile concern at this point. And so this is a kid in which I would go ahead and order a routine EEG. And I think from a primary care perspective, that's totally appropriate as well, if you're comfortable doing that. One of the finer points of EEG that I think could be very helpful that I wanted to point out is that when a kid has an EEG, there are 3 factors we do to try to provoke abnormalities, because EEG is not perfect. And, you can look at it for 30 minutes. And if it happens to be normal 30 minutes, that may not be as helpful as if it had been an abnormal 30 minutes. We do photic stimulation, we do hyperventilation, and we try to have the patient go to sleep. I think that's especially important for this kid for a routine EEG, because the episodes are happening during sleep. We know that as you transition to sleep, you are more likely to kind of throw off any abnormal discharges that are hiding in your brain. So when you order a routine EEG, especially in a situation like this, having the patient come in sleep deprived for the EEG is, I think, very important. And sometimes I think that doesn't happen in kids who come in, or they just can't go to sleep. But kids who come in and get an awake EEG that's normal, I don't know that I'd feel as comfortable with that in this situation, in the setting of a kid who has jerking spells at night. I think if you're very concerned that, it sounds like mom has tried to stop them, I think there's a couple things you can do. I think you can have mom try to video the episodes if you're not convinced. You can have mom try to keep a spell log if she's not convinced. A lot of times they haven't tried to touch the kid to stop the episode, and if so, tactile stimulation is important, because a lot of people have not really tried that. They may have called their name, something of that nature. And if you're really concerned, I think you can, consider a medication or referral to neurology. And if you're going to start a medication, this sounds like a kid that really needs to see neurology at some point.
Any questions about this case or ways that you and if you've seen any patients with similar presentations, how have you handled those, or have you done anything differently? Is there any problem? I have some questions. So would there be any problem with, if the parents are very anxious about what she gives us history of increasing frequency, we're going to refer to the neurologist, but we can't get in for 2 months or 6 weeks. Would it affect the EEG if I started her on, say, something like Keppra?
Yeah, so that is a great question. And the answer is it might affect the EEG a little bit, but I do not think that the risk and benefit analysis of a kid who we truly think is having seizures, a kid who is having seizures can have a normal EEG anyway. And at the end of the day, seizure is a clinical diagnosis. So if you think that the kid is having seizures, if we together think that the kid is having seizures, then that's a kid that should start medicine. We don't want to hold off for 3 months pending an EEG, because what if it's normal? Are we not going to treat them? If we're clinically concerned, then I think the risk and benefit is on the side of treating. Going ahead and
as a response to therapy might give you more information.
Yeah, and that can give you information as well. Sometimes if we've started a kid and episodes don't change at all, they don't change in frequency, they don't change in length, nothing changes. Sometimes then we'll do a long EEG and try to actually capture the episode. But sometimes once we've started medicine, if mom says, well, now they only happen once a month, it's probably a pretty good indication, if we took a good clinical history and had clinical suspicion to start with, that we are treating the right thing and maybe just needs a medication adjustment to get rid of the rest.
And it doesn't basically condemn the child for lifetime medication at that point.
No. It doesn't change it at all. It does not change their long-term course of what we do at all.
Any other questions about the case, concerns? Dr. Wallace? Ms. Carroll? Oh, we can't hear you. No, I'm not good at lip reading.
We can see you, but we cannot hear you.
Okay. Okay, some technical difficulty here. We're getting it. This does bring up one issue with Brian. If people want to submit like a written question, if they're in front of a computer, there is a chat function down at the bottom, correct, Brian? Yep. And so you could actually type your message here just for future reference. Down there at the bottom, I don't know if everybody can see that, but there's a little kind of like a chat cloud, and you can click that, type in there, and that could be sitting there in front of us while Dr. Xixis maybe is finishing discussing a point, so you don't forget it, like I would. And so you can do that. So, Ms. Carroll, are you having sound yet? Not yet.
Not muted.
And you're not muted, so something must be your microphone and your computer is turned off or something like that. You're not muted within the Zoom software, but your microphone on your computer might be turned off. Okay. Okay, well, she's trying to solve that. Why don't we, any other questions about the case? If not, you're just, we had one. She was typing. Okay, I know that I am totally uneasy starting medication on my own. I want the neurologist to bless it.
Yeah. Yeah, and I don't think you're alone. So I don't think that makes you very unique from that standpoint. So, I think that depends on the neurologist. And so, in this venue, it's me, but depending on where you are or who the patient is seeing, it could be someone else. I think that most pediatric neurologists, including myself, are happy to make a recommendation. We don't want the child to be out there seizing for 3 months while they're trying to come into our clinic. And so from a recommendation standpoint, officially, that you can write down, I talked to neurology and they recommended this medicine and this dose. I think that's totally fine for most neurologists. I can't speak for everyone. I would say that if you're in a pinch, and every neurologist has gone to a conference in a foreign country, that you usually are not going to go wrong starting Keppra. Keppra is not going to make different types of seizures worse. So whether they have absent seizures or complex partial, whatever it is, it may not be the best choice for that long term down the road, but you're never going to hurt anyone, and you're probably going to help some. So if you were in a pinch, Keppra would be the way to go, or levetiracetam would be the way to go. But certainly I don't think that, communication with the neurologist that you anticipate them seeing would be a bad thing at all.
And based on this case scenario, what kind of seizure type do you think this child may have?
I don't know. It depends
Just
on
really
our
hard to-
information. Yeah, I mean, it sounds like it's a generalized episode, but with it starting during sleep, you don't know if it started partial and spread. If we did our EEG and it had partial, focal abnormalities, we might think more about a focal problem that spread.
Okay.
Yeah, I don't know.
So just to put a plug in, so we're having a 4-part series. One of those series will be on medication initiation based on seizure type and that sort of thing. So we'll be talking about that.
Different pitfalls of different medicines. And
So I'm glad we got to use our chat session, that chat function. That's good. So anybody else, any other questions or comments? One of the goals we hope with this echo session is that, and this topic of seizures might be a little more complex than it might be not as much of that. But if you've had cases in the past where they have been managed differently, or you did different approaches, we want to hear from you, because there isn't necessarily a one-size-fits-all for all this stuff. So please feel free to, from your own experience, what you guys have done, or in working with a neurologist, what your experience has been. With that, I guess we should go to your presentation. And Brian, I'm going to try and see if I can do this. Okay. Brian's going to coach me. He's our...
Does somebody chat?
Someone?
Someone.
Oh, there's another chat in there.
Okay.
Dr. Barty, to everyone. Great session. Where is Dr. Barty? He hasn't weighed in on that. Are you on, Dr. Barty? You can text us back. Okay, so we're going to go to screen share. I'm going to go to my desktop, right?
Download for the presentation?
Yeah, for the presentation.
Yeah, go to download Logitech. It's different.
Okay,
right there. An additional chat. I just didn't know if it was someone had asked a question.
That the yellow echo. There you go.
Okay.
And then
presentation.
And these are going to be available. We decided we're able to.
Oh yes,
they're already there.
Right.
Okay.
Present. Oh boy. There you go. So we're gonna send out more information on this, but we will be having a website where all this material will be located, not only the PowerPoint, but then Dr. Xixis kind of put up there some links to AAPhealthychildren.org, some patient education materials, which Pam Meyer has recommended that we do. So that was good.
I'm going to check make sure someone that have a question that we didn't get to answer and they have to leave. Nope. All right. Okay, so let's see if this works, hopefully. So within these sessions, the idea is to have kind of a brief didactic. This one is a little bit longer than some of the ones that we will have, just as a form of an introduction. And each didactic hopefully will build on the cases that we've discussed, and hopefully cases that you guys will bring to the table as well going forward. So let's see if the clicker will click.
I can do it here.
Can I just use that?
Yep.
That way?
So you can do it right there. Boom.
Okay, perfect. Okay. All right. So I don't own anything, so we're good. All right. So let's go.
Just a mortgage.
Just a mortgage. You can have that. So, all right. So introduction to seizures, just to talk a little briefly. And I'm going to go fairly quickly through this, and I'm going to talk not necessarily off the slide per se, but as we said, this is all going to be available to you, so you are welcome to keep it for reference going forward. So when we think about seizures, our first question is, what is a seizure? And the point is that, you know, a seizure is often a sign, and it may be a sign that you have illness. It may be a sign that you have epilepsy. It may be a sign that you have had brain trauma. But it's certainly just a situation where the brain gets angry enough to fire off an abnormal discharge. And the definition of epilepsy comes up a lot. And I actually get parents who get very upset when I code epilepsy on their checkout sheet. So, you know, the definition of epilepsy is simply 2 unprovoked seizures. 2 unprovoked seizures in life that are greater than 24 hours apart. So it's pretty easy, actually, to meet that definition. Occasionally, we will also diagnose people with epilepsy when they have a clear epilepsy syndrome. So if we know that you have, you know, absent seizures or juvenile myoclonic epilepsy, we know you have epilepsy. If we know that you have had only 1 seizure, but your MRI reveals a significant congenital problem where we think, you know, we're just waiting for you to have another seizure, that may be a patient we're comfortable calling epilepsy and treating as such as well. Let's see. Okay, so can it go away? It's a big question in pediatrics. Sometimes, it depends. If your MRI or your EEG are very abnormal, that's going to be less likely. If you have a certain seizure syndrome, we know that you're not going to outgrow. That would be less likely. But for a lot of kids who have random seizures, they will often outgrow them. And we do certainly look into that possibility as they grow older and not have any more on medication. All right, so why do kids have epilepsy, and what do I do about it? So whether or not we're able to stop medication ever, whether or not we start medication, you know, really depends on what kind of seizures they're having and how many that they're having. So we're going to talk briefly about first-time unprovoked seizures, and then we're actually going to talk about febrile seizures. It's a little bit backwards, I apologize. So first-time unprovoked seizure is someone, they don't have a fever, their, you know, sodium is fine, nothing has happened, they're having a regular day. And classically, we talk about everyone gets a free seizure. You had a seizure, fine, you know, we're not going to start you on medicine next. That's mostly true. But, you know, every person with a first-time seizure does need this workup. And the workup is a routine EEG and an MRI brain without contrast. It's not something that has to be done that second if the patient is stable, if their exam is otherwise normal. But in the next few weeks, it needs to be done and assess their underlying risk. And as I mentioned earlier, if someone has a significant underlying risk, their EEG is terribly abnormal, their MRI is significant with problems, then those are people we might say, oh, I don't think your first seizure was free. Let's go ahead and start a medication. But for the average person, a first-time seizure is going to be kind of a free pass from starting medication.
But wouldn't those children, they'd have other symptoms or signs, usually developmental issues or some sort of dysmorphology necessarily?
Not necessarily.
Not
Sometimes.
necessarily.
So certainly it may be more common in those kids, but we see kids who are doing great. They get, you know, they have a first-time seizure. We do an EEG and they have significant just sharps all day long in a certain section of their brain. And so that just may be their first presentation. So it definitely is important. It is the recommendation, but you do get information out of doing these basic studies after a first-time seizure for sure. So the choice to start an anti-epileptic medication then, that's what I mean by AED in this case, is going to be based on that workup. So typically the answer is we're not going to start a medication unless there's a significant abnormality that really says we probably should go ahead and do so. Waiting to start that medication, some people may think, you know, if I wait, am I going to cause damage? Is something, you know, going to cause harm in terms of the kid's long-term prognosis with seizures? And no. So if you start medication after the first seizure versus waiting after the second seizure, that doesn't make them more or less likely to be easy to control or hard to control. All right, so I think we've kind of covered this. Basically, you know, we typically wait to the second seizure to start an anti-epileptic medication unless we find significant abnormalities that really suggest we should do otherwise. However, children who have had a first-time unprovoked seizure should definitely have a rescue medication. Classically, that's going to be the rectal diazepam as we were discussing earlier. Certainly, a kid who has a first-time unprovoked seizure, we've talked about, oh, it's fine, we'll do the workup, we'll kind of move on. Certainly if they're ill appearing, if they have significant abnormalities from their baseline neurologic exam, kids can present with a first-time seizure with meningitis or something else. So certainly we all know that would be a very different situation than a well-appearing child. Typically, a first-time seizure, if a primary care physician is able to get an EEG and an MRI and they are normal, that kid does not necessarily have to be seen by neurology. I know sometimes it's driven by the family's anxiety, and that's certainly fine. We're happy to talk to them, but really it's not going to change their management to see neurology. So febrile seizures, which was really more the topic of most of our discussions today, although we did kind of hit on a possible new onset of other seizures. So febrile seizures, by definition, they're going to be a kid who is well appearing. They do not have a central nervous system infection, but they do have a fever greater than 100.4 Fahrenheit. It is by definition 6 months to 60 months. So a child who is 7 years old who has a febrile seizure, that's not a febrile seizure. That is a seizure probably in a kid who is hiding epilepsy and has kind of been tipped off by an illness. About 5% of kids will have a febrile seizure. So as we mentioned before, very, very common, and therefore something that we all really need to be comfortable with. This is a review of the criteria we discussed. Simple febrile seizures, they're generalized, they're less than 15 minutes, there's only 1 in 24 hours. If any one of those things is not true, that bumps you down to the complex febrile seizure category, and that's going to change your workup. So the risk of epilepsy after a simple febrile seizure is essentially unchanged from if you had never had it. There is a slight increase in risk for folks with complex febrile seizures. I tend not to harp on that with the family unless I'm directly asked, but there is a little bit of an increased risk for folks with a complex febrile seizure. One question we get about fevers and seizures is, do you do an LP? And so, in the setting of a kid who is well appearing, who is kind of bounced back, is now running around the room, probably not. We get worried about kids who are less than 6 months old, which is not really a febrile seizure. We get worried about kids who may be pre-treated on antibiotics or kids who maybe are not appropriately immunized for their age. So certainly, just like you would with anybody else in those situations or immunosuppressed, those are kids I would think about. But a kid with a regular, simple febrile seizure who clearly has a URI and otherwise is fairly well appearing does not need an LP. So what workup do we do for a simple febrile seizure? We talked earlier about nothing. So no EEG, no imaging, no electrolytes, nothing like that is needed. You can do the rectal diazepam as we said. You can also wait until the second time, depending kind of on how anxious the family is and how you feel about everything. And otherwise, they do not necessarily need to see neurology either for simple febrile seizure. Same thing, we're not going to change the management. We're certainly happy to talk to them about it. Complex febrile seizures we talked about are a little bit different, so it does matter in terms of defining what exactly has happened. A routine EEG is what we're going to start with. We're going to follow that up with imaging if the routine EEG is abnormal. And these are kids that typically will err for rectal diazepam in a complex febrile seizure more than in a simple febrile seizure. And these are kids that are typically followed peripherally, at least by a neurologist, because of the increased risk kind of going forward of potentially having epilepsy. So this is just a blurb about febrile seizure prophylaxis. We talked about using clonazepam, which is the most common that we use as a bridging medication during febrile illnesses. Certainly, as I mentioned, the studies in the early 90s actually started with oral Valium, but really for the dosing and ease of administration, clonazepam is by and large most typically used by folks, typically twice a day for 3 days during a febrile illness. One common misconception is that antipyretics will help. If I keep their fever down, they won't have another seizure, and that has not been sustained in studies that have been done, even though it seems to make sense and kind of thinking about it. But febrile seizures tend to happen with rapid changes in temperature, and therefore when you are using Tylenol, your brain is already angry enough to throw off a seizure if it's going to. And so keeping it down will make them more comfortable, but it's not going to prevent a seizure. Are we okay on time? Or?
Yeah.
Okay. So we are going to talk a little bit then about seizure safety, which I have found is a really big thing that comes up with parents after their kids have one episode. You know, they're terrified. Can they do anything? I had a poor little girl the other day that wasn't allowed to go to the movies or the carnival because she had had a first-time seizure. So, you know, we try to, you know, weigh the risk and benefit of living in the setting of seizures. So the first thing I tell families is that physical injury is the big concern. I'm more concerned that you're going to drown or fall down the stairs than that your short seizure is going to cause any permanent brain damage. And classically, 30 minutes of continuous seizure has been used as a cutoff for concern. I will say some new studies show that maybe it's a little bit shorter than that, but there's no kind of conclusive evidence on shorter times than that. So I usually quote families about 30 minutes. When a patient has a seizure, we ask them to place the patient in a safe position. So if they're in a height, in water, on a tile floor, you know, protect them from that. Turn them on their side so that children will often drool or vomit after a seizure. We certainly don't want them to aspirate if we can prevent that. We do need families to note the time. So you guys have already heard, and you guys give families rectal diazepam and, you know, for 5 minutes, but how do we know when it is 5 minutes? And families will always think that a 30-second seizure has been 10 minutes. So please, you know, I try to say you have to time it so we know how long it's been going on. Do not put anything in their mouth. They're definitely not going to swallow their tongue. And do not try to restrain them. So I let them know, you know, holding them down, the movements are coming from the brain. It's not going to do anything but potentially harm the limb you're trying to hold down. So during a seizure and after a seizure, patients are often going to be tired and confused. It's okay to let them sleep. I do let families know if they're able to arouse them. That may be with pinching, that may be with a little sternal rub, whatever they have to do. The patient should have some kind of moaning, groaning response to them. If they have no response at all, I tell families you should be worried. But I do try to let families, especially of patients who come with recurrent seizures, know that every single time you have a seizure, if it's fairly typical and you're returning to baseline, you don't have to go to the ED. And a lot of our chronic seizure families will finally kind of get used to, this is a normal situation, you know, we can handle it. Obviously, if a patient has an extra long seizure, they're not able to be woken up, there's noxious stimuli, does nothing, that's concerning. If they're turning blue, that's concerning. If it's very atypical for them, that's concerning. So a known seizure disorder patient, once they have had a seizure, if they're returning to baseline, I try to educate families again. They don't necessarily even have to be seen by EMS. Certainly if there's a concern, call EMS. But if not, then just let them recover. And then if a patient with a known seizure disorder is not returning to baseline, then we certainly do want them to be seen because seizure patients obviously can get sick too. Briefly, I'm not going to read every word of this. I'm going to kind of tell you the gist of what I tell families in a nutshell about what can I do and what can I not do. For water, we tell them, please, we prefer that you will shower instead of take a bath. In a bath, you'll drown. In a shower, you may hit your head, but at least you won't drown. We say that swimming in clear water is fine. So that means the swimming pool is okay, but rivers, lakes, oceans, not okay. For heights, we say, you know, we want you to be as normal as possible. If your seizures are relatively well controlled, we'd like you to be able to do normal things, play normally, but please don't have rock climbing or house painting as your favorite things to do. For playing, no reason at all that children with well-controlled seizures should not be able to play sports like anyone else. So we do encourage them to do everything that they want to do if they're fairly well controlled. Driving laws vary by state. It's important to remember that ATVs are also considered motorized vehicles, no matter how old the kid is. And it's also important to remember that if a kid is changing medication, that is also a time in which they are unable to drive, even though they're seizure-free, quote. So I simply say to families, if my kid had a seizure right now, could I live with the result of that? And if not, they should not allow their children in that situation. Okay, so very briefly, we are almost done and almost out of time. Well, just thinking about epilepsy, because coming up, we're going to have multiple other sessions about all different forms of epilepsy. Oh, this slide did not do well, huh? I think hopefully you can see it on your version because the other is missing. But when we think about epilepsy, we kind of alluded to this earlier. We think about a partial epilepsy. You can be simple, partial with maintained mental status, complex partial, where only one area is shaking, but you're somewhat confused, or it can start in one area and then spread. There's also generalized epilepsies, and those are going to include things, and again, I apologize if you can't see it, but things like tonic, clonic, tonic-clonic, myoclonic, atonic or drop seizures, as well as some of our epilepsy syndromes. All of those are going to go into the generalized category. So going forward in other sessions, as we talk about different forms, we'll start to talk about what the difference is and what differences in medications mean for these. So again, we're going to talk about all of these different forms of epilepsy coming up in future sessions. The idea is that if you can recognize these, you can figure out what to treat them with and how to best kind of guide the patient. I believe that is it.
Great. Thank you, Kathryn. We really appreciate that. We're coming close to the end of our hour. I did want to, I'm going to stop the presentation. No one's asleep. That's good. That's a good sign.
Good start.
Because we couldn't see you while the presentation was up. Brian, I want to just mention briefly at the end here is that you can get CME credit for this. We're on our website. You can really just Google ETSU's Project Echo CME, and it'll get it to our website. Brian, do you want to be able to show them how to do that? Okay, so Brian, our wonderful technician person, knows how to do this. She's going to just show you on the, here we go. So this is our ETSU CME. Let me just talk them through it. This is ETSU CME main website. So then you go down regular scheduled series to Project Echo. He's going, oops, go back up, right, down to Project Echo, right? There you go. So he's going to go to Project Echo, and that's at me. Am I doing that? Oh, I'm doing that. I'm sorry. So go to Project Echo. Here's the main page for our Project Echo, and then you can see some fact sheets, some information, and you would click here for the evaluation. This is our October 13th. There you go. You fill out the evaluation, and then you submit down here at the bottom, and you get CME credit. Isn't that correct? Anything more they need to do?
After you click submit, the request for credit form pops up. You would download and fill it out, and then.
Okay. So then when you hit submit, a form will pop up. You print that out, and you fill that out. That's your CME credit form. Anybody have any questions about that? Also on this webpage, I just want to point out is that we do have a description. We have some Q&A. So if you want to show people this and say, here's a kind of an overview of what we're trying to do, you can see that. Here are the next sessions, November 3rd, January 12th, March 2nd. We'll be sending out endless emails about this. And I will be sending out a better email. Oh, here's a lovely picture of Donna Doherty. She's out here in the room. She's our CME coordinator for this. We want to thank her and Brian for all the work they did to set this up. And then we have some resources here. This is good. So session materials, let's just click on that and show you that we have from the Echo session 1, is this it right here that I should,
The PowerPoint?
that's the PowerPoint.
Yeah.
There you go. I want to go, how do I get out of that then? Do I go?
Just close it.
Close it. Okay. And then where's the
links from the bottom.
right down here, the link? Okay, so this link here shows you materials with kind of web links to patient materials from healthychildren.org, our AEP partner for patient education materials. I think that's all I've got. I want to take a picture of that because we want to show. Next week, I'm going to the American Academy of Pediatrics, NCE, and presenting with them on our just kind of how we got organized around the Echo. This Echo is really going to get a lot of support from the AAP. So we really appreciate everyone participating. And if anyone else, oh, Helen, we got something from Helen here. But let me just finish my sentence. If anybody else you know that would like to participate, direct them to our website and have them download Zoom. And now that you're an expert, you can show them how. So Helen Johnson had one quick question. Wanted to clarify. First time unprovoked seizure, not febrile, big kid, needs an MRI as well as EEG. I've not typically done MRI if EEG was normal or had a normal CT from ER.
Yeah, so that's a good question. The CT is okay. And I think technically it would qualify as head imaging. The guidelines that I've read kind of fall in that category. It's okay, but MRI is preferred. And the reason is, again, going back to that dysplasia piece. If we see a kid on MRI, which won't be seen on CT, that has significant area of dysplasia, meaning abnormal, like gray matter in the brain, then those kids are increased risk for epilepsy. And we may very well, depending on what it looks like, even consider starting them on a medicine. But there's no perfect answer. So if there's great concern about sedation, if the kid has lots of other ventilatory issues or the parents, I think you're probably okay to kind of sit with a CT for the first time, but an MRI is preferred.
Great. Thank you for those questions. Those are good questions. Well, with that, I think we're going to wrap up this first echo session. I want to thank everyone for attending, and I hope that you found it productive. We do have your evaluation form, so to get the CME credit, we really appreciate your evaluation input, or send me an email if there's some things that you think you'd like to see us do better. We are actually in the process of setting up our cameras, so we're going to have a little bit higher resolution camera for the next session. But thank you so much. Appreciate it. Bye.
Thanks, bye.
Bye.
So end meeting. Boom.